Okay, so good afternoon, class. This afternoon, there is an emergency situation wherein we have to go later to Maranding again to be with the bereaved family of Pastor Lopez. As you all know, last yesterday, the father of Pastor Lopez died. So the school administrations and uh, wants to condole with the family of Pastor Lopez. So we'll be leaving early. So that's why I'm having this recorded lecture regarding the problems of the foot and the upper leg. No? So this afternoon we're going to discuss compartment syndrome before we will proceed to the actual problems of the ankle. So compartment syndrome. What is compartment syndrome? Uh, Compartment syndrome is an elevation of interstitial pressure in a closed fascial compartment that results in microvascular compromise. Uh, it is true that it is an orthopedic emergency. When you say orthopedic emergency, you need to attend to it immediately because if not, the foot will suffer from ischemia and later on maybe gangrene and eventually lead to necrosis, which will results to amputation. So what is a compartment? It is a closed area of muscle group, nerves, blood vessels surrounded by fascia. Now, in our leg, just like in the thigh, in other parts of the body, especially in the limbs, muscles are arranged in different compartments and surrounded by one fascia. This arrangement is called osteofacial compartment. Now, within the compartment, there is a pressure. So usually the pressure within the compartment is about 5 to 15 millimeter mercury. That is the normal. The intracompartmental pressure rises to 35 to 40, then that will lead to compression. So let's take for example here the compartment of the forearm. So we have the lateral, the medial, and the dorsal compartment. So we call this as the mobile wad, no, ang lateral niya. So compartments of forearm. So these are the components. So we will not focus on that. We will go directly to the uh, compartment of the foot. No? So we have now the compartment of the legs. So here we have now the compartment of the legs. So there are how many compartments of the legs? So basically we have the anterior, posterior, and the lateral, no? And also the deep posterior. Okay, so these are the compartment of the legs. We have four. So you have your anterior, lateral, deep posterior, which is responsible for inversion, and your superficial posterior, which is responsible for plantar flexion. So the lateral is for eversion, and the anterior is for dorsiflexion. Now, why I emphasize their action? Because if the compartment of the leg or a specific compartment is affected, especially let's take for example lateral. If this lateral compartment is affected, then basically the signs and symptoms would fall on the absence of eversion, and maybe your uh, slight dorsiflexion will also be affected, no? Can be weakened. So etiology of the compartment syndrome. So basically there is an increase of fluid content within the compartment, or maybe because of decrease of compartment size because of bone injury, cast, or bandage. Basically, in decreased compartment size, it can no longer accommodate the, especially in deep fascia or in deep bones, no, or in the third degree bone. Usually the fascia, if the fascia is born, then it shrink. At the same time, the muscles inside the fascia also swell. So there are two areas to be concerned: the swelling and the shrinking of the fascia. So what will happen to the inner structures, especially the nerves and blood vessel? It will be compressed, no? Because of the buildup of fluid within the fascia that shrinks. Then you have increased fluid content. So here, basically because of trauma, that results to fracture or burns, hemorrhage, vascular disruption, or puncture or snake venom. That would result to increase in compartment syndrome. So if the uh, prolonged, no, increase of pressure within the fascia is not released, this is what will happen. No? So there is the results of tissue death, and it will lead to amputation also. So acute compartment syndrome is considered as medical emergency caused by severe injury. So the classic sign of acute compartment syndrome is pain, especially when the muscles within the compartment is stretched. The pain is more intense than what would be expected from the injury itself. Using or stretching the involved muscles increase the pain. So, siyempre kay ang compartment nimo tight na, so hindi mo siyang i-move ang muscle, sakit yun na siya. Stretch nimo, ikuan, no, sakit, no? Okay, simple na ipit naman gid siya. And maybe there will be a tingling sensation. So if there's a tingling sensation, such as paresthesia, nanay nerve affectations. Numbness and paralysis, usually that is already the late sign, no? It involves the nerve na. So ang kuan lagi danan niya is pain. So kung pain gani claudication, so kuan lang na siya affected, maybe blood vessel or blood flow. Chronic compartment is known as exertional compartment syndrome, no? So kani balik-balik. It is not a medical emergency, most often caused by athletic exertion. So chronic compartment syndrome causes pain or cramping during exercise. This pain subsides when activities stop. And it most often occurs in the leg. Symptoms may include numbness, difficulty of moving the foot, and visible muscle bulging. Most times, muscle cramps. Kuha na siya. Sa high cost run na siya sa kanabitang muscles, wala dahil maka-exercise o wala masanay, no? Kalit lang nag-demand siya og oxygen. Yan, nakulangan. Munang kinana. So, all you have to do is to rest. Then after that, pwede na pagka mabalik sa activity. But as long as the muscles will get used to it, mawala na po na. Tissue survival rate. So, unsa may tissue survival rate? So usually kung unsa gyud kadugoy na iha madamage sa muscles or ang tissues. So let's take for example for 3 to 4 hours nga na-compress siya, ay ang cell barbiturate ana is maayo pa kay reversible pa ang changes. 6 hours nanay damage ang tissues. 8 hours, more than 8 hours nga na-compress siya, irreversible na. So mo nga medical emergencies gyud ang compartment syndrome. That is for the muscles, but for the nerve, even 2 hours, no? Nga na-compress na siya na, nakay no neuropraxia. So, lisod-lisod na, no? Loss of nerve conduction. No? Hinay, or maybe wala na yun. 4 hours, wala na, complete disruption. 8 hours, irreversible na yun. So, delayed diagnosis will result to permanent sensory and motor deficit, contractures, infections, and eventually amputations. So, pathophysiology, mao ni siya class. So, magsugod-sugod na siya sa reduced blood flow. Oh no, direct injury. So, it's all starts here. No? Direct injury. So, ma-increase ang compartment pressure, ma-reduce ang blood flow, may ischemia, so, arterial damage. No? So, inana siya sa cycle na. Magbalik-balik. Kung dili siya ma-disrupt nimo diri pag-anchor sa compartment, applyan ni mag fasciotomy. So unsa may unsa may kuan nga makilala ka mag fasciotomy kung naa na ni painful, pale, pulselessness or pulseless, paresthetic, paralyzed, fasciotomy na dayon kakunan siya. So usually I experience this when we have a born patient in the hospital. No, I think there are about 30 born patients no, at one time. Ay nasunog man gud ang factory ato sa plywood sa Hingoog sa sikat nga plywood factory. So diri sila gidala sa Iligan kay dili makuan dito sa Hingoog Sanitarium. Nagdara di sa Iligan. So at start dili man na nimo makitaan pa ang compartment syndrome no. Siguro mga 5 days, 4 days after nga grabe na ang edema. Dira na siya kana nanay shrinkage sa scar or nanay scar formation no. So, gahi maguno siya nga panit no nga niggahi. Pag ma-form na siya dira na siya magsugod ang compartment syndrome kay katong scar dili naman to siya stretchable no. Kuan na to siya hukot. So kung mag-build up ang edema dito sa sulod makumpan. So alatub tayo pila ko ka basis nga naka-perform og fasciotomy. So I am so fortunate at that time no because I was really kung sa pa na train ko pag treat sa burn no especially in performing sharp and blunt debridement or debridement of tissue. So inana nindot siya no makita gid nimo ang relief no the one time I have there's a patient nga ang nagka-problema niya is the upper X. Kita nimo yung upper X niya kanang ilham nimo sa mga born patients no nga na siya ay compartment syndrome. Usually the hands will undergo claw hand deformity. Ano man ang edema mo abot man siya diri sa tudlo no. Pagabot diri sa tudlo mag-ana na din na ma-extend di ba na flex ana ra siya. Kani hukot na kaayo imong i-touch it's already non-eating edema. Kay kani sunog na diri is scar na siya diri. So maro bitaw kita mo ng latex nga latex nga gloves puti mao na iyang color. Anaon nimo di na mag-blanch no puti na lang yun siya di na magbalik ang redness no blanch na lang niya siya pale na. So slowly amo tong gi-remove no diri tanggal o ana giupakan. So, pagkatanggal gyud nga na-release ang diri nga compartment automatic nagluag nag-move hangtod ni abot diri sa anterior nga part na-release ang pressure nag-ana. So pasabot it can move the finger now can move and slight ada. So hangtod nga napanitan siya taman diri natanggal no nakat naka-move balik ang fingers ug na-relieve siya ang pressure. So it's an automatic no. So time is very important no when it comes to debridement no especially in born cases with compartment syndrome. So these are the cause no. So this is the cycle. So you have trauma, increase in tissue pressure, venous pressure, arterial pressure, they will be increased. Decrease of arterial, but okay, siyempre naipit no. So wala na blood pressure nga blood nga oxygenate lang sulod pero ang venous pressure nimo increase kay mo stuck man dito ka compress. So vascular spasm, ma-increase na siya kay wala na siya oxygen supply. So every gradient, blood flow. So dugangan pag i-apply tourniquet kay nag-trauma. So mo na iyang cycle. Magbalik-balik lang na siya kung dili nimo siya ma-applyan og what you call it fasciotomy especially on this portion no dire na. That is the pathophysiology. So history and physical examinations. So these are the basic signs and symptoms that you can see in the patients. Paresthesia, so this is a symptom. So numbness, pallor, that is a sign. Pulselessness, that is a sign. Pain is a symptom. Paralysis is a sign. And poikilotermia. Di na siya ka-regulate siya ang body temperature because again, the sweat glands is already lost. No, kay open naman. Wala na may skin. So, ana siya. Siya ka-regulates body temperature. As well as fluid also. So, kasagara gyud makamatyan sa patient nga burn, no? Especially if it is more than 30% sa bato TBSA ang napasok or total body surface area is dehydration. So naay patient ana no along the way gagibiyahe nila from Higoo paingon diri Iligan may pa may istorya pag abot sa ER napalong kana namatay siya sa dehydration kay ga-evaporate ang imuha fluid. So differential diagnosis for compartment syndrome. So you must learn how to identify if it is a cellulitis ang problema sa patient, DVT o thrombophlebitis or gas gangrene or necrotizing fasciitis or peripheral vascular disease. So kani sila sila kalainan sa compartment syndrome. Let's say for example cellulitis. Ang cellulitis is pallor, paleness, cold, no, clammy kay wala man siya arterial supply, di ba? So bugnaw na siya. Pero kaning cellulitis init. Thrombophlebitis and DVT. So may kalainan. Thrombophlebitis positive sa human signs. This one wala na sign. Kay di na ka-move. Di ba? So ana siya. So evaluation, so you have here pwede ka magamit og mga physical examination. So you have assess tenderness in the muscle compartment, evaluate motor and neurologic, so sensory and motor assessment no na apat. And the radiograph should be obtained if there is a fracture site. Ay dana siya, no? Una po na siya tig-monitor sa pressure. So, intracompartmental pressure, if it is greater than 30 degrees, indicates compartment syndrome. Investigation, so you can do now full blood count, coagulation profile, creatinine phosphokinase, urine myoglobin, X-ray, and ultrasound. So unsa may management nato na surgical fasciotomy, no? So importante dira surgical provide supplemental oxygen kung sa mga pampa na experience na nila while nag-cast, then removal of the cast and keep the extremity at the level of the heart, never elevate, no? Kay base may kang edema ni swelling ni ipataas nako, no, ipataas mo na samot na siya, no? Prevent hypotension and provide blood pressure support in patients with hypotension. So kung acute compartment, urgent decompression. So you have your fasciotomy. After fasciotomy is performed and swelling dissipate, skin graft is most common, no? Closure man, i-close man nimo. So skin graft, nganong skin graft man? Remember, nagdako siya, nag-inat. So nimo siyang get-remove ang fascia, nakagitanggal. So manghita ka og itapak atong imuhang part nga gikuhaan nimo fascia. Kung may necrosis, so you do fasciotomy and amputation or maybe debridement. Now you know now how to debride. So you can use a lot of technique in debridement, no, as PT. As PT, you can use wet, dry, sharp, blunt. Okay? Inana. Kung dry, mo na magamit kag mga kabantay mo ng goose, no? May pasto, butangan nila goose kan, butangan na goose kay dry debridement na. Pag ugah sa goose nagpilit man to, matanggal to ang dead tissue mo uban sa. But it's very painful. No? Pwede nimo siya i-combine ang wet and dry. No? Example, na siya napaso or na siya katong necrotic tissue, pwede nimo siya butang to. Then pagtanggal nimo to, pwede nimo siya ibutang sa tubig, i-whirlpool. So that is a combination of two, wet and dry debridement or debridement. Or you can use the sharp using now i-combine it with wet, no? Kasi siyempre pag igo to sa agitator sa whirlpool, mahumok ang tissues, you can easily cut the tissues nga nagpilit-pilit. So that's combination of the two. Oh, you can use blunt. When you say blunt, for forceps na gamiton, no? Panitan. but it requires strength at the same time. Uh, you must know where to apply the angle of pull so that matanggal. Dili nimo siya sa isa ra ka direction i-pull, mo siyang ayun na ahadap ito siya nga humok, no? Muna siya technique nila sa blunt. Fasciotomy is a surgical procedure where the fascia is cut to relieve tension or pressure. So, ana siya. So for me, it was just fortunate nga I have worked with a surgeon, no, sa hospital. So, Doc De La Cruz, Doc, uh, it's a mga Dr. Gayaw. So I have worked hand in hand with them in doing the debridement. So that's why I gained also their trust. Now we have born patient before they just trust it to me. Now you do now the debridement on your own. So nindot siya, no, kay through that I have gained experience in doing debridement. No? But of course, if there are emergencies like just like bleeding, profuse bleeding, arterial, yeah, I cannot kuan anak nga ako lang. So I have to call their presence also. So ganalan may pug ka ma-identify kung ano siya bleeding niya. Kung venous raman ang nakat, dali ra kaayo kay applyan ra nimo pressure ana, no? Dali ra man siya, pero kung artery dugay class knowledge. So you need to have extra kuan yun nga makukot yun siya nimo. Or sometimes you have to apply a tourniquet. So mo ni siya management na to, no? Kung na fasciotomy, nag-scarring formation. So diri na ta masulod yun as PT. So mo management sa scar formation. So this is an example of no, on how to release the pressure. So here that's diri na siya ang incision nga na ay posteromedial, posterolateral. So kani siya anterolateral, kani nani this is anterolateral. So duha na ka compartment ang naigo ni the anterior and the lateral. Kani siya is posteromedial, kani this is a posteromedial compartment nga cut. So duha na ka compartment, the posterior and the medial compartment is ginatreat. So ana siya, no? So para ma-increase ang pressure niya is mag-low up. Oh, so nana mo na yang nawong, no? So fasciotomy. So look at what happened to the tissues. Kani siya kung nadugay. O kani mo pud ni, no? Sa hand na gani siya. Kani sa foot. Imagine that. Dako kayo, no? Pag open niya, buska diretso. Pero maayo po na kay na-relieve ang pressure. O sometimes sa burns ang mogawas dira dili dugo. Mogawas dira is nana. Bayin bako pag yun, no? Pag kuan nimo dito ang necrosis, like diabetic foot nana gyapon. Makita nimo siya diabetic foot kaning nag-itom lang murag 25 centavos. Ya ga hubag na. Ya di ni malihok. No, nya naigiitom pud diri sa tumoy-tumoy ani giitom. Pag open nimo ana, muagas din to, grabe na ang necrosis. Diri pang puncture nimo ana, agoy grabing sulod. So pag uwan nimo, wala, bukog na lang, gamay na lang ang nabili niya unod. Nya baho kaayo pag yun, no? Baho pag yun kaayo. Baho pag yun kaayo ang baho pag yun kaayo ang agas, ha? Ang agas sa dugo. Itom naman, no? Murag lapok, nya baho. Kay mo kag na napay daghan ana kaubog yun, no? So kailangan medyo kung mao gani ng inyong case class, it is burn, compartment syndrome, diabetic foot ang patient, prepare na lang ang daan mo sa inyong strength sa inyong gininhawa. So complication of fasciotomy, altered sensation within margins of wounds, dry scaly skin, pruritus, iatrogenic neurovascular injury, swollen limb, tethered scars, and recurrent ulceration, pain related to wound. So all of these class needs to be addressed by the PT, except for this pruritus, no? Pangatol man na, tambal na, dry skin, we have the skin care, no? Nga naana siya sa pareha naman na sila skin care, no? Foot care sa naa sa diabetic nga atong akuan sa libro ni Delesa na dira, no? Diabetic foot care, swollen limbs, scars. So how do we treat scars? So kinahanglan siya atong naanay ginatawag na garments nga isa loob para makompress ang scar. Then naano siya katong anti-scar nga ointment no i-apply. Then ato siyang i-press. So ina na. Chronic compartment syndrome, so conservative treatment lang include rest and anti-inflammatories and physical therapy. Elevation of the affective in the patients with compartment syndrome is contraindicated. If symptoms persist after conservative treatment, or if an individual does not wish to cease engaging physical activities, that would bring to fasciotomy. So dito na siya. So sometimes sagod mas misdiagnose nato ni no ang compartment syndrome usay atong una compartment syndrome pero dili dito. It could be an intermittent claudication. So ang problema to kay DVT-DI no or yeah, thrombophlebitis. Ano man siya no. So ato nang bantayan no. So complications naman na siya complications niya, permanent damage and even amputations. So kung ang patient na to, matod pa kung gusto gid siya mobalik, kung kuhan siya, kailangan din siya pag-undergo fasciotomy. But after fasciotomy, it would take time also for you to return. Why? Because of the scar. Scar formations and fibrosis. So, management sa scar, unsa man. So, applying ka sa mga anti-scar na ointment, then siyang stretch kay para ang tensile tension sa muscles ma-rearrange siya balik sa normal. Okay, kung nag-scar na ang muscle fiber, wala siya mabalik sa normal nga arrangement, bungkag. Okay, remember fasciotomy gud ang perform. Na siya na-damage siya gidya sa sulod dito ang muscle tissues. So after kwan kinahanglan na siya og thorough nga fascial release and myofascial nga massage para ma-rearrange ang fiber sa muscles para ang ilang tension balik siya sa normal, maisa na lang ka direction para ka-produce og smooth contraction. Now let's go to neuropathy. So sa neuropathy, atay tibialis posterior neuropathy. Mao ni pinaka-common. So what is TPN or tibialis neuropathy? Okay, nadre. No? TPN is a pathologic condition of tibialis posterior nerve. Wide variety of symptoms but must be differentiated from peripheral neuropathy. So, what happens the eye? What happens? What happens when your big toe touches something? How do you feel it? Di ba? Imo siya ma-feel, no? No. Kinsa may nagkakuan na? It's your tibial nerve, no? Man na siya nag-supply din tibial nerve na dira sa lapalapa. Kayon sa big toe. Na. Internerve plantar nerve. However, these signals don't travel superficially but traverse deep into the foot, no? So kana diri mao na siyang sensation na then moagi dili na siya mo ambak nga ang matukos laing nga no diri masubay na siya. So asa man na siya maipit gihapit? Dira dapit siya sa imuhang abductor hallucis brevis. No kani? Abductor hallucis brevis. So, abduction, kani siya nga nerve, nga muscles. Could be a big source of trouble if it crushes the plantar nerves. Its function is to stabilize the medial column. The foot, the first tray, what would happen if this patient had a hypermobile medial column? Maipit yun, no? So, critical kaya na siya diri sa medial side. Oh, kana siya, no? Dira siya nag-create sa tunnel, dira siya maipit. The porta pedis is a very concerning area, no? Okay, so parehas na siya sa no, opposite sa dorsalis pedis, posterior man na. The porta pedis is a very concerning area as the medial and lateral plantar nerves travel towards the spine. Their path is transformed from horizontal to vertical. So porta pedis tunnel is created mostly from fibers of attaching adductor hallucis muscles belly to the calcaneus along with the dense connective tissue similar to the flexor retinaculum. So construction of the porta pedis, morning maigo niya. Not only the nerves, but as well as the arteries and the veins. So sometimes plantar fasciitis also affects that one. Maglako na gid ang edema. So mo mga contents sa porta pedis nato. So kung mag-constrict na unsa man, mainani siya maipit. Ma-crushed. No? So effects of talodorsal dislocation. So during gait cycle, what happens to the porta pedis? So inani. Okay na siya. Pag humani mo, pag land sa foot, heel strike mo na ni ang paingon sa mid-stance mo na ni ang problema. Kaya nga naman, dislocated man siya, collapse man tong medial arch, no? So, maipit siya. Inana. So, dira diri siya mako na siya sa medial maludis dapit sa ilalim lang, no? So, the rectus rear foot alignment will not place additional strain on the porta pedis or combine. So, kay lahi man. So, bisan ka ni mausab ang alignment ani niya, it's either mo tilt na siya diri or tilt laterally, dili dapat kagulaan, no? Kay lahi man ang compartment niya. So, ang problema lang nato na kung naa na siya deformity such as this one. Usually, paingon siya sa tunga. No? Paingon sa tunga, dira man ang bagbend. So, mag-pronate ang foot, no? Kung supinate, okay lang. So usually sa pronation. So this will place a tremendous amount of destructive force on the contents of the porta pedis and tarsal tunnel. So metabuan na niya, mana normal nga tarsal tunnel. Kaya na siya dira. Pero pag mag-collapse na siya, mag-close na, wala na siya lungag. Wala na siya agyanan. Mag-close na siya dira. So, ang problema na sa titi mo, wala na, magtungas na din to ang problema. So, unsa may atong management, ana, kung naa ka dira? Say atong management, ato ta sa management, no? Ato ta sa management. Na siya management diri. How we can fix this problem? So basically because na misalign ang foot sa may atong management. So you have your shoes, ba, art support, no? Shoe modifications or orthotics, di ba? Ito ka mag-provide ka og orthotics. It would be knee, ankle and foot orthosis or AFU, ankle and foot. No? You could have also vitamins. No? So, hinana siya. So, atong man siya. So kani siya internal problem, so it demands internal solutions kung na-damage na gyud ang nerve, no. So kung na-damage yung nerve, mo na ng problema kung na kay pins and needles, so maybe because of diabetes, alcoholism, or chemotherapy, yan lahi na siya nga istorya, no? So kung problema pud ka sa tarsal tunnel kani increase pud siya, ah, maybe decompression, no? But basically, kung ana gyud foot tungod sa uniformity, then you have to settle for AFO or ankle foot orthosis. Shoe modifications will help a lot. Okay. So diri mana siya. How to eliminate hyperpronations, orthotics, special shoes, braces, splint and exercise and stretching. So mo kinay management niya sa ato ang foot. So it must be custom molded orthotics. When you say custom molded, kinahanglan naa na siya no, magtunog ka dito. Then ano siya clay, patumbong ko sa clay, makita dito ang foot nimo. And out of that, dito na magsugod ang modification sa foot, no, na sa PVC, no, nga himuan siya pattern. Then dito na i-mold ang iyahang support sa imong arch, no, sa foot. So inanay example, no, cadaver sit up. So na orthopedist niya, no, dira maay man dito, no, na love gyud nila, no, ato diri wala man gyud, no. So inana siya class, no. So dito